Welcome to Module 5. You have made it through 4 modules so far, so what you have learned is the background information. You have learned about some of the new position statements and consensus statements within athletic training. You have learned about things such as how to remove football equipment, how to see if there is a spinal cord injury. Well, now you're going to move into some of what does evidence say. So for this module, you actually do not need anything special, so you may continue on. So within the position statement, you have seen things such as strength of evidence, and you'll see at the bottom a little bit, it'll say like A, B, or C. And these are depending on the level of evidence and how much research is put out. So we know that A is the highest, and we know that this is seen because it is consistent with good quality care. Some of B is made because, yeah, it sounds good according to research, but there is inconsistent or limited patient-oriented evidence. And C is just the complete total together. So what we're going to do first, we're going to start with some of the traditional techniques that are used and also talk about some of the unique types of spine boarding that are possible. So first I'm going to talk about the log roll, and as we said, with EMS they will only use 2. With athletic trainers we typically use 4 people to help with this, where you have somebody at the head and 3 people consisting of the roll. And we know that although this technique has been one of the oldest used, that is not necessarily the best. So if a patient is supine, the 2 main lifts that you will use is either the log roll or, as we'll talk about here shortly, the A+ lift. And log roll used to be the preferred method, but now we're seeing that there's more motion within the log roll. So we get a lot of translation within the cervical and thoracic spine when rolling the patient on. And this is because of the sheer motion of how you're getting the patient. So when a patient is supine, you're going to have to push or pull them up to a certain degree, traditionally around 90, to then get the board underneath to be able to lay it down. And this can cause some motion if the person at like the head or the shoulders isn't moving at the same speed as somebody is moving on the rest of the body. Another idea that has been used is the scoop stretcher for a supine patient, in which the spine board will actually, it opens up at the bottom and you go down and you attach it, and you can pick the patient up and then place them onto the spine board from there. This idea sounds like a great concept, but the issue with this is that the scoop stretcher will sometimes pinch the back of the patient, and another issue is that it doesn't provide good stability. So the patient is scooped up, but there is no true stability happening. The motorized spine board is a cool new invention that's come out that is actually, it looks like a little conveyor belt, and it's placed right under the patient's head and they're slowly pulled onto it. There's not a ton of research done out there, but talking clinically, the ability for a clinician to have this is not very well known because it's so expensive. So it's not going to be something that we focus on today. Another use is the C-collar only, and this was used by paramedics because of the amount of times that they were spine boarding and the injuries that can result from it. So being on a spine board for too long can result in bed sores and additional pain and pressure points. However, we know that with athletic trainers, if we've already deemed it necessary for the patient to need spine boarded, we should make sure that this is something we communicate with EMS prior, but it should be something that we fight for. If a patient is prone, you have 2 options. So you have the prone log roll push or the prone log roll pull. And both options are used. Just from my experience in talking with other clinicians, more people traditionally have used the pull than the push, but that's not necessarily true. I would like to challenge you guys to kind of take a look at what you do. The prone log roll push is slightly better according to the evidence. But here's something I want you to remember. So that within evidence-based practice, there's 3 components. So your first component is the literature and what it says. The second is the best outcome for that patient. And the third one is the clinician's experience. So if you are experienced at using the prone log roll push, great, because that's the slightly better one according to evidence too, if the patient is in the correct position to be able to use that lift. However, if you traditionally use the prone log roll pull and are very comfortable with it, have had success, and the patient is in a spot that could be used, then I recommend going with that. Because, like I said, remember that you don't necessarily have to always go by just what the literature says, because we always know that can be changing too. One thing I really want to mention for the next lift is the 8+ lift. This used to be known as the 6-man lift, and nothing has changed with this lift, just the name. And that's something that they brought out with the new consensus statement. And if you think about it, it's just because it takes into account how many people are actually taking part. So you have the one clinician at the head, 3 on either side, and 1 pushing the spine board in. So we know that 8 people are needed to perform that lift correctly. So we know that as you're stabilizing the patient, you want to make sure that you keep inline neutral head stabilization. So what this means is if the patient's head is deviated to the right or left, or if it's flexed or extended a little bit, you want to make sure that you bring it back into alignment. We want that spinal cord to sit as comfortably as we can right in the spinal canal. This can cause any decreased signs and symptoms and can also help prevent some injury. So far we've talked about situations where the athlete is on either concrete, or they're on a court sport, or they're on grass or turf. And although this happens, there's unique situations that we as athletic trainers need to prepare for. What I encourage you is to determine what sport you're working and seeing where you could potentially have to spineboard somebody at. So a few examples of this are within gymnastics. They will vault off and go into a foam pit during practice to reduce the amount of impact on landing. And at times you're going to have to spineboard in the pit. There's a few different methods that have been used. Some places actually have a spineboard that will be able to be lowered in and can pull the patient out that way. Other places will put boards in and have the athletic trainers kneel on those. And the reason for this is because in the foam pit, depending on your motion, you're going to continue to sink. The one thing you always want to make sure you watch out for too is to cause the least amount of motion. So you're going into an unstable surface, and as you're going in, you could potentially be causing more harm to the patient by having them move, which is opposite of what you're trying to do. Another instance of where you want to make sure that you have a good communication to prior to having to spineboard is aquatics. This can be done a few different ways depending on the location you work and the certifications that you have. So depending on where you work, you may or may not have a lifeguard at every practice. For some of the bigger colleges as well as professionals, this is something that would happen. But at a high school or even a smaller college, you will not always have a lifeguard available. So at this rate, athletic trainers need to know how to be able to stabilize in the water. If a lifeguard is present, you also have to come into the decision of how you're going to work together. So sometimes what they will do is athletic trainers and lifeguards will actually work together to be able to take the patient out of the water as one. Sometimes the athletic trainer will become lifeguard certified and be able to do both jobs at once. And some athletic trainers will not want to spineboard in the water at all because that's not something they're comfortable with. I recommend that you're going to have to obviously make your own decision, but that you work with whatever personnel you have available to make sure and ensure that the patient will be able to be properly treated if a spinal cord injury happens within the water. As you can see here, too, with the picture, ice hockey is a unique situation to have to spineboard. And for those of you who haven't worked this sport before, it has a lot of challenges when spineboarding. So one of the issues is simply getting out to the patient. You have to make sure that you do not slip and fall on the way out. Another consideration is that as you're out there stabilizing and transporting the patient, you're going to be kneeling on ice. And one recommendation is to, if you're going to be out there for a little bit, have somebody bring a towel and to place that on the ground and kneel on the towel. When lifting, you need to make sure that you have a stable base of support because you will not be able to push off like you traditionally would on the ground, and you don't want to be the person who slips or causes any additional motion for the patient during the lift. So if you do work ice hockey, I know that you would be out there practicing, but it's just something, again, to reiterate that the importance of practicing within the specific venues of where you work or could work. So we know that based off of the position statement that this equipment-intensive sports, the choice is yours, and each athletic trainer must decide within and of themselves what they're going to do. If they're going to remove all the equipment from an equipment-laden athlete, or if they're going to use leave it on and transport the patient with it. So this is something that you as an athletic trainer must talk with your EMS and also must talk amongst your staff and decide together what you're going to do. So at this point, we also want to consider additional sports, and we've talked a lot and will talk a lot about hockey, American football, and lacrosse. And we know that these are the sports that have the most literature on them. But if you can see, there's another 7 sports or sport groups listed here that have cervical spine injuries with equipment. And these are not researched. And this is something that is concerning for me and should be for you too if this is a sport you work. So things such as field hockey with the goalies and all the equipment they wear. In addition, women's lacrosse has padding that's similar to men's lacrosse for the goalie. Even things such as like equestrian with the helmet, like if somebody got thrown from a horse. Baseball, whether it be the baseball catchers or even the batters and base runners. Softball with the catchers and batters. Cycling helmets. You have the X Games and winter sports, and all these things are things that if you're an athletic trainer working this event, you need to practice and work ahead to know how and or if you're going to take the equipment off.